Dr. Sue Flocke, who will be presenting this afternoon. No one should have to do their own introduction. So Dr. Flocke is here today to present her work on one of the topics that we actually introduced at our Dissemination Day, or Research Day back in May, for those of you who may have attended, when we talked a lot about our tobacco work that was ongoing. So this is kind of an update on that work, where Dr. Flocke is now on her project, implementing an evidence-based strategy in primary care, ask, advise, connect, and eReferral to reduce tobacco use. So our typical structure is to take about 45 minutes for the talk. Most of our talks are pretty open, and so questions along the way, certainly. We'll be sure to leave some time at the end for questions and discussion, because that's always the fun part. I would also just like to remind you all that we do have our annual calendar seminar series listing schedule. Thank you. Couldn't find the word. It should be right outside, and hopefully you all signed in. But if you'd like to get a copy, please take one. We welcome you to join us every second Wednesday here at noon. So as I mentioned, Dr. Sue Flocke will be our speaker today. She is an Associate Director of our Prevention Research Center for Healthy Neighborhoods, as well as a faculty member within the Center for Community Health Integration, which is also located up on the 4th floor of this building with us. And so, Dr. Flocke.
Great, thanks. Hi, everybody. Welcome back to our seminar series. I get to kick it off, and I really want to make it clear that this is a huge team effort, and throughout I'll have an opportunity to point to a couple of other people who were tremendous in helping with this project. But before I even launch, I do want to acknowledge the funders of this through the CDC as well as through PCORI. And I have a lot of slides here, and I think what I'm going to do is just sort of see how we go in terms of time, and I might skip over something, so I hope that that's not too disorienting. But just as an overview, I'm going to talk a little bit about the prevalence of tobacco use, and particularly in vulnerable populations as a setup. And then we're going to talk some about healthcare systems approaches and something that we've implemented in partnering with Metro Health, and the approach of making community linkages, clinical community linkages. So if you're enjoying the banana bread with chocolate chips and sort of zone out from that sugar buzz during the talk, I'm going to tell you what the take-home messages are right now. And I know that there's a handful of people that need to leave early, so good thing I put the slide in early. So the take-home messages are that tobacco use is prevalent in Cleveland. It's actually very high. We've learned that healthcare systems-based approaches can reach a large portion of the population. Connecting community resources to support tobacco cessation treatment is indeed effective, and using systems approaches to focus on stakeholder strengths really is a great way to go. And I think that this project that I'm going to tell you about really exemplifies that. From a broader context, there's been a recommendation, a movement to move Cleveland to cut the tobacco rates in half. That is a large target to shoot for, but this is really going to require multi-level approaches, and what I'm going to share with you today is just one angle on a strategy that ideally would be combined with a variety of other kinds of approaches to tackle this enormous problem. So just how enormous is this problem? Tobacco still is the leading cause of preventable death in the United States and responsible for 500,000 premature deaths per year. The map shows the VRFSS data across states, and states with the highest prevalence are shown in darker blue. In Ohio, the rate is actually 24%, but in Cleveland, where our little star is, we have estimates of rates of tobacco use among adults at 30%, which is about twice the national effort. We know that tobacco is strongly associated with poverty. U.S. adults below the poverty level are almost twice as likely to smoke. And locally in Cleveland, and these data come from the PRC from a data collection in 2012 and 2015. On the left, you see Cuyahoga County, and on the right, you see Cleveland, and this breaks down smoking rates by income. And you can see a strong association that those that are in the lowest income categories have exceptionally high rates of tobacco use, and that tapers off as income increases. And we see a very similar pattern when looking at education levels. So poverty, education levels, we know that there's a correlation there, but certainly very strong association with tobacco use. So in terms of reaching individuals with low income that might be high levels of tobacco users, we did a little side study investigating what's actually happening with federally qualified health centers, and learned that tobacco rates among federally qualified health centers, those that serve low-income folks, tend to be on average 5% higher than in the states in which they come from. Overall, the range of tobacco use within states among federally qualified health centers varied and varied dramatically. But this was just one window into looking at the prevalence of tobacco use in these clinics that are serving mostly underserved. We have some colleagues at Metro Health. So Metro Health, I think many of you would be familiar with, is our county hospital system. They have a hospital and they have outpatient care sites. They serve for the largest portion of uninsured and Medicaid in the city. And they have a diverse number of community-based primary care clinics. They also have an interesting history having implemented EPIC as an electronic health care, an electronic health record in 1999, and have achieved, and this is the little bubble in the bottom, they've really achieved high-level recognition for their usage of the electronic health record, and really using it for not only care and quality of care, but for outreach and in other kinds of quality improvement kinds of initiatives. And they're very interested in partnering to address tobacco rates. And this is because when we look at the tobacco rates among patients at Metro Health, and this is a 2-year look back among those that were in a primary care outpatient clinic, and that the rate, the little pointer works. Let's see. Okay, great. So this column, so 32.7% current smokers, looks a lot like the city of Cleveland. And of those 44,000 folks, you can see the majority of them are Medicaid, Medicare, or self-pay, which would be uninsured. Okay, so this is a high-risk portion of folks who are smokers, and a partner that would be interested in working with us on addressing smoking cessation. Coming together, we were really interested in developing an approach or a strategy to tackling smoking and smoking cessation that could be replicated in other systems and regions. We wanted something that was going to be sustainable across time and not dependent on a research team that was going to come in and change things and then take it away and then just leave the organization trying to figure out what to do next. And that it really fit the needs of the organization and the patient population. So coming at it from this context, really thinking about partners' needs, who are the other stakeholders, and then coming at it from a whole systems approach led us to some more refined questions like, how do we optimize adoption of evidence-based cessation strategies in this kind of a community clinical practice setting? And then beyond adoption, how do we sustain use? And also, what kinds of approaches could be used to connect patients with tobacco cessation resources that are likely to be effective for them? So this is where I'm going to tuck in a little sidebar. I'm throwing out some terms that maybe are a bit of jargon to some folks, and one of those would be around dissemination and implementation research. So this project is very much about dissemination and implementation of evidence-based strategies. So let me help define a couple of those terms. So first, dissemination research is study of the processes and factors that lead to the widespread use of evidence-based practices, whereas implementation is really understanding the processes and factors that are associated with the successful integration or uptake of those evidence-based practices, and trying to understand that and how one might adapt what's known to work into local contexts or other kinds of settings. The other jargon word would be evidence-based interventions. And evidence-based interventions are practices or programs that have been have some science behind them. They've been peer-reviewed, they've been documented to actually work, versus evidence-based implementation strategies. Again, more jargon, but this is the approach, I like to put it as, this is the approach of putting it into place and keeping it in place, and really understanding what factors are associated with the strategies and activities that actually get that uptake to happen. There was a really nice article that came out from Karen Emmons and Graham Kolditz highlighting why implementation science is important for tobacco, but also for other kinds of health behavior change kinds of things. And it points to the need to focus our attention on understanding how to implement effective strategies and adapt strategies to effectively work in specific settings. And they're really calling out the fact that smoking cessation has the longest standing evidence base, but that as a nation we've not been implementing what seems to work. So with that, where we went next was to start to identify some evidence-based strategies to address tobacco and tobacco cessation in partnership with Metro Health. And I've listed a couple of things here, and I'll go through and talk a little bit about each of them. The first is the Quitline. So you all might be familiar with Quitlines, or at least think you know a little bit about them. Maybe some of you have worked with them in the past. But Quitlines are evidence-based strategies for assisting tobacco cessation, and it basically boils down to phone counseling. So it's telephone counseling that's tailored to individuals. And Quitlines are available in all 50 states, although the format and the eligibility tends to vary based on how much that particular state wants to invest in that service that they're providing. So for example, when our project started in the state of Ohio, it was a fairly narrow slice of individuals who could get Quitline counseling for free. That included people who were uninsured, pregnant women, and individuals who are on Medicaid, but only fee-for-service Medicaid, not any kind of a managed care or PPO kind of Medicaid. And for anybody who knows the profile of what it looks like in Ohio, fee-for-service is a very narrow slice of folks who have Medicaid. And if you asked a patient, what flavor of Medicaid do you have, most don't know, and nor does the provider or a physician that you're going to see know what kind of Medicaid that person might have. So at that point of care, we don't know if you're eligible for the Quitline services or not, so we're not going to send you, was the general stance. In July of 2016, the state expanded who they're going to provide Quitline services to include everybody who has some flavor of Medicaid. So that was a great move on the part of the state. In the state of Ohio, if you do enroll in Quitline services, telephone counseling services, you'll get up to 5 counseling calls that are tailored to you. It's tailored to the time and your individual needs of what you'd like to receive. It's available in a wide range of languages, like 200 languages. And that really does fit for some practices that have individuals who are coming either with an interpreter or that they need to use interpretive services. The calls can be arranged to suit the individual in terms of what time, and currently there is free nicotine replacement medications that come with engaging in counseling. We know that nicotine replacement therapy, like the patch or gum or the lozenges, in combination with counseling can greatly improve your chances of success at a quit attempt. Okay, so what we know is that if you engage in Quitline counseling and get through 5 or so counseling services, your likelihood of being smoke-free after 6 months is about 20%. If you add on nicotine replacement therapy, it's about 35%. The estimates are kind of all over the place across the country and across Quitlines. But I think that's a good general rule of thumb. But with Quitlines, few patients call on their own. The uptake is actually about 2%. So in the old style of when they used to have the little cards, 1-800 quit now cards, the doctor said, I strongly recommend you quit. Here's the number. Why don't you give them a call? Okay, thank you very much. It's about 2% that will actually call. Clinician recommendation has low yield on calls. This idea of a direct referral, like a fax referral or an electronic referral, seem to have a much better yield. It's about 50% will engage. But because of office operations, fax referrals have not been widely adopted. I don't know how many of you still have a fax machine that you can access. It's probably now your copy machine in the office, but faxes are not frequently used. We talked a little bit about eReferral, so this is sending an electronic referral. This is actually a brilliant idea. eReferrals directly refer the patient to the Quitline using the electronic health record, and what happens is that when that eReferral is sent, then the Quitline proactively calls the patient. So it's the Quitline calling the patient back and engaging them to enroll in the process. So this is a fantastic strategy. It's been implemented in a couple of places. It's been around now for about 10 or 15 years. And it certainly has a lot of benefits, one of which is that they call the patient, and it gets over that barrier. Information actually comes back to the medical record so that the clinician and clinical team knows what happened. And there's really greater volume and efficiency that could happen. Here's a cartoon of how it works. Basically, you've got your electronic health record. Through a secure data exchange, information goes to the Quitline. The Quitline actually calls to engage the patient. In Ohio, they get up to 5 call attempts to try to reach them, and we'll leave a message. And then information flows back about whether the patient engaged or not, or completed counseling. In Ohio, remember I said that there was a fairly narrow, not everybody is eligible for the Quitline. So behind the scenes, what we've developed with Metro Health is to determine eligibility based on insurance type. And that happens behind the scenes so that the provider or whoever is making that recommendation doesn't need to know their insurance type. They just need to ask the question about whether they'd like to be referred and press the button, and they go. So you might be asking yourself, well, what happens when people are not eligible for the Quitline? And that's a great question. We wanted to make this process work for everybody. If they're not eligible for the Quitline, they go to an in-house program called Freedom from Smoking, which is an in-person 8-session class. Okay, the last piece of our strategy is Ask, Advise, Connect. And this is a systems-based approach that asks about smoking status, provides advice to the patient to quit, and then connects those that are ready to quit in the next 30 days to the Quitline using an eReferral. What's innovative about our approach, and we've based this off of something that had been tested in Texas by a consultant on our project, is that the medical technical assistant, or the person who rooms the patient and takes some of the vital signs, is actually doing this whole process. So I don't know whether there's any physicians in the room, but we've bypassed you on this step, which is a good thing. Okay, so I've already commented that somebody else has done this and actually has had really good results. So what we did in terms of the project was to work with our partners to establish this e-referral capacity between Metro Health and our Quitline provider. Quitline provider for Ohio is National Jewish Health, located in Colorado. We designed changes to electronic health record and made changes to workflow for the MTAs and nurses who were going to room patients and go through this Ask, Advise, Connect process. We've developed a training and many support materials. We tested it in 2 clinical sites that were on main campus, and then we rolled it out into 8 community primary care sites. Here are some of our partners and a couple of the folks that have been involved. In terms of the eReferral study and the EHR changes, we changed data fields. We've added suggested phrases for how to make it happen. I'm kind of glossing over some of these things. This third bullet in particular, building the connection capacity to be able to do the e-referral to the Quitline, that took about 2 years to do. So it took a little while, and it's a good thing we had a running start with one of the projects and then picked it up with another project. It was a substantial amount of work to get that cracked. There were other things that were built in, and we were learning a lot working with the information systems team, and they were just absolutely fantastic and flexible in helping us accomplish this. Along the way, we also had a lot of input from the people who were going to be using it. We knew we had to have buy-in, so the medical technical assistants and nurses, we were constantly going back and asking for representatives and input on the process, and making sure that when we were ready to roll it out, it wasn't going to get spit back in our direction saying you guys are nuts. And in some ways, they really could have told us that we were nuts, because this is what the MTAs and nurses would normally do. They would ask about tobacco in the last 30 days, and if the person was a smoker, they would document things like how much they're smoking, what they're smoking, and when they started. So some history kinds of things. That's what they were routinely doing, and then moving on. This is what we were asking them to do. Provide advice, and we gave them a nice statement as a member of your healthcare team. We strongly recommend that you quit using tobacco. To then assess their level of readiness to quit in the next 30 days. We kept it really simple. Are you thinking about quitting in the next 30 days? If that was a yes, then they were offered an opportunity to be connected with a coach or a counselor that could help them quit. And if that was yes, then we would have something that would pop. They could press the button, place the order for the Quitline referral, and it would go either to the Quitline, or if not eligible for the Quitline, freedom from smoking. And then the MTA would move on. So at first there was a little bit of concern. One, we're not allowed to place orders. And we said, well, for this you are. We've made it fine for you to place this order. And then they were also a little concerned about providing advice. We said, this is it, this is the phrase, you can do this, it's fine. And then highlighting to them that while 30% of their adults are smokers, only a smaller percent are going to be interested in making a change, and a smaller yet are going to be interested in having a referral. So the whole activity would really be a very small portion of individuals that they'd be interacting with. We developed a lot of support materials, a tip sheet for MTAs and nurses that was modeled on how Metro Health actually rolls out other kinds of changes to electronic health record, posters for the clinical areas, and then information for patients that show up on the after visit summary form, which is that cluster of papers that you get that summarize what the heck happened in your visit and what you're supposed to follow up in doing. So this is our tip sheet. It ended up being, this is just a screenshot of it. We had some really great input from the EPIC trainers and the MTAs and nurses on how to design this so that it would be useful, and it basically walks everybody through exactly what you need to do. And it was great because if there was a new person that came on board, somebody could train them off with the tip sheet on how to do this. This was one of the posters that we hung in the practice in a couple of key areas, just as a reminder, and keep it on the MTA's and nurses' mind. And this is not a very good screenshot of a screenshot of a screenshot of what shows up on the after visit summary form, but what's highlighted there is giving them a heads up of what phone number to look for in the next few days if the Quitline is going to call them. Because it's an 800 number, and not everybody picks up an 800 number, as we know. So we try to give them a heads up of what to expect. Okay, so in terms of implementation at each site, we gave a very short presentation on the idea and the process to explain it to them. We also had a couple of plants in the audience on our team, and found that really helpful to say, yeah, I've been through this, you know, I helped design it, it's really okay, it's really easy to do. We had a hands-on demonstration with test cases, so folks could sit down and actually click on through with some practice patients and get a feel for where to look and what to do and what got, you know, where people got stuck. The information systems team was super helpful in making that happen for us. We distributed the tip sheet, we hung up our posters, and we said start today. For each practice where we rolled this out, we turned on the capacity the day we did the training. Actually, we did it in the morning, and we were delighted with one practice that we went to that somebody said, yeah, I already saw that, before we even got there at 9 o'clock in the morning to try it out. So there's a long introduction, but coming to our study design, I call this a pragmatic trial, and we'll be doing an analysis of interrupted time series, but we rolled this out in 8 sites. And you can think about it as each site having a pre-period and then a post-implementation period. Most of our data came from visit-based data from the electronic health record. We, of course, measured a lot of process variables of ask, advise, assess, readiness, and connecting in terms of what got documented in the electronic health record. In terms of outcomes, we were really interested in, for those that were referred to the Quitline, was the Quitline able to contact people? Did they answer the phone? Did they enroll? And if they enrolled, how many counseling sessions did they get? And did they get nicotine replacement medications? We also collected data on patient survey in periodic subsamples. Mostly wanted to know about their experience. In process right now, we're doing some qualitative interviews with some subgroups to understand a little more deeply about their experience. And we also did informal and formal feedback sessions with the practices themselves, and I see that as a data collection point too. This is what our timeline looked like. Thanks to India Gill for putting this together for me. November 2016, and we rolled out at our first pilot site, our 2 main campus ones, in December and January, made a couple of modifications, and then rolled it out as quickly as we could into these practice sites. Most of the practice meetings, it was during their quality meeting, and we just got scheduled when we could, but tried to get these as quickly back to back. Okay, we did gather some feedback pretty immediately after doing the implementation, wanting to make sure that it was going okay, see if people had questions, if we were annoying the heck out of, the MTAs. And that feedback was super helpful in making a couple of modifications to the process. Little tweaks, but it made a big difference to them. We could talk a little bit more about that in the question period if there are some. We also provided formal feedback. And the formal feedback, I guess I'll show you a picture of that in a little bit, but it was about at 2 to 3 months out. We'd let them know how it was going and provided back some data, and then also invited opportunity for them to give us comments and questions, but use that as an opportunity to give them a booster of reminders for where it wasn't going as well as it could be. Okay, with that, here we go to some data. So it's a lot to look at. I've pruned it down to 3 months. Many thanks to Steve Lewis for generating data, and data hot off the presses as of last night at 9 p.m. This is new. You're not going to get anything newer. Okay, so what you're looking at here is the month before we launched. These are all 8 sites combined together, and then 1 month after, 2 months after, 3 months after. I wanted to give you a sense of the volume of the patients that are coming through. Okay? So, before we launched, 25% of all patients were being asked about smoking status. After, we bumped it up to 37%, stays at about 37%, 3 months after we're at 40%. And again, the before and the after months is variable based on when we launched for each site, okay? So you can see the number of people are being identified as tobacco users. Okay, this is not small, a lot of people. We have 2 different advice statements. That's kind of a longer story. Some things we could change, some things we could not change within EPIC. This is our new one. We had to build a new thing. I'm pretty sure that this is a possible error in terms of timing because it didn't exist before we rolled it out. But this is EHR data. We have to investigate. But essentially, this didn't exist. But look at these rates. They're doing a great job implementing this whole new practice of asking and providing that brief statement. As a member of your healthcare team, I strongly recommend you quit to people who are identified as smokers. Assessing readiness. Before we rolled it out, this button did exist. It was at 18%. It could be a physician who's filling that out. It could be anybody who that patient saw during the visit that was filling it out. After we implement, we're in the 70%, 68%. We're tailing off a tiny bit, but overall doing a great job of assessing readiness. Not everybody's ready, and that's fine. We actually encourage folks to stay pretty neutral. It wasn't to persuade people to become ready, but rather for those who express their readiness to offer them something if they'd like it. And you can see how many people were actually accepting a referral, going to either Quitline or Freedom for Smoking. This is the number of people who are getting connected with resources that otherwise would not have. So pretty exciting. This is just 3 months. I want to show you this, and Steve did, just a simple contrast of looking at 1 month before versus the 3 month mark. So we have data across all 8 sites on the 3 month mark. So I just selected that. Again, we can see the number of visits, and then we're just putting it into odds ratios. So this intervention across these 8 sites had a 2-fold increase in the asking rate, which is great. We've had a 40% increase in the original ACO, the original advice statement. The other one, it didn't exist before, and now we're up in the 70% range. It's not fair to create an odds ratio there. In terms of assessing readiness, 8-fold difference. That's great. And then this one, there were not a lot of referrals being made before this got rolled out. Now there's a lot being made of those who are ready, such that we have a ridiculously gigantic odds ratio. This is what the data looks like graphically. This is ask, and the different colors represent the different sites. And you see there is some variability here. And it ends, some of the sites rolled out later than others, so we don't have a month 5, 6, and 7 for them. This is what it looks like for our new advice statement. I just found this one the most exciting because I was concerned about whether or not these MTAs were going to adopt this statement we made up for them. This was new, remember? The one thing they did was ask. They didn't do anything more. So the fact that there was good adoption and that we've got some above the threshold of 80%, I think is just something to dance about. In terms of assessing readiness, again, we see some variability in uptake, and one practice in particular that has really nosedived on this activity. So we'll go back and find out what's happening there. We have some debriefings, but I think we have an opportunity to examine characteristics associated with uptake, which is something that we'd really like to be able to do. So in terms of a summary of the process variables, we have substantial increases on these indicators for all sites. The MTAs and nurses tell us they like the process. They actually feel pretty empowered about it, and that they've incorporated into their workflow. And that for most sites, the changes have been sustained across time. I said that we had done a formal feedback on what we call a booster session. This was super short. We tucked ourselves into another quality improvement meeting, gave a 5-minute update, provided their practice-specific data, and then used that as an opportunity to emphasize a couple of key reminders, like you need to push the button, mark as reviewed, otherwise it doesn't get documented. A couple of key things that we wanted to make sure that folks were remembering to do. Here's an example. I cut it off, but an example. So over on this side would be the practices data, and this is how this is everybody else. This is their 7 comparator sites, and then we gave them the detailed data below. But folks were appreciative of that. We did collect some patient survey data. We collected a subsample. We're planning to do 3 different points in time. Before we rolled out Ask Advise Connect, after we rolled out Ask Advise Connect, and the 3rd point in time in the future, after we roll out another intervention that we've planned. And we were going to make sure that we have subsample of about 18 per clinic per time point. And I have my rule number 1 down here. Our main reason for collecting the patient surveys to make sure we don't mess up patient satisfaction with practices. Patients are pretty happy with their practices. Don't mess that up. So overall what we see is before versus after. And you can see things are pretty much the same. Did these things happen? Let me go to this one. Overall, they're reporting that the nurse or MTA was more likely to talk with them about smoking. A couple of other things increased. And I think overall, we just wanted to make sure we were not creating any tension with regard to their satisfaction with that visit. But this is a nice validation that from the patient perspective, some of these activities are happening a little bit more frequently. Okay, let's talk about Quitline outcomes. So there were 1,438 patients referred to the Quitline during this time period. Our contact rate was actually less than 50%. So even though all these folks are saying, yes, I'd like to be connected, phone number gets verified, the Quitline goes to call them, and they're not able to reach that person. They're labeled as unable to contact. It is a fair amount of folks. On the positive side, there were 219 folks, or of the people who were able to be contacted, 219, that's 38%, actually agreed to participate and enrolled in some counseling. And that wouldn't have otherwise happened. We have some folks who they were able to get a hold of them, they chose to decline. Maybe it wasn't at all what they were interested in at that time. And then we've got this other group that's fairly large, 209, which is 36% of those who are reached, who are waiting for intake. And what the Quitline tells us that category means is that they were able to get a hold of them. They said they didn't want to talk now, call me back at another time or a different day. Okay, I'm not convinced that a lot of those people will convert over to enrolling, but that's what we've learned so far. The unable to contact, this is a really sizable group. It's 56% of the overall, even after 5 attempts. This is a challenge. This isn't unusual, as they tell us. Our data doesn't look like anybody different from others, but I don't know. I thought we were going to be better than others, and I think we still might be. But we have a lot to learn about that group. But let's talk about who did enroll in the Quitline. So what we're looking at here is folks who enrolled. They were slightly more likely to be female. They definitely were more likely to be older. So this is, of those that are age 65 and older, 21% actually enrolled, compared to, of those 18 to 34, only 8.5% or 8.8% actually enrolled. African Americans were slightly more likely to enroll than the Caucasians that were sent. Okay. In terms of medication, so again, remember I told you that nicotine replacement therapy is free with this, if indicated, and females were, of the females, 79% had medication, so slightly more likely than the males. Not gigantic differences among age, but the younger adults were more likely to have medications. And again, no big differences between African Americans and Caucasians. In terms of the overall number of counseling calls, they could have up to 5. Very few people had 5 calls. The average was actually 1.7, and some modest differences between, but mostly in the age groups. So clearly this phone counseling is not the thing for the 18 to 34-year-olds. It's just not their thing. But the older adults, they kind of liked the calls and engaged in more of them. So there might be something to understand a bit more about this in considering alternative modalities of engaging people who are ready to make a change. So what we summarize from at this point is that the systems-based strategy really did result in some substantial changes and in sustained changes in the documentation of status and advice and being able to connect to assistance. The uptake of the Quitline counseling favored females and middle and older adults, but as I just mentioned, there's really a lot to learn about individuals who say they're ready and want help but aren't able to be contacted. I think that our qualitative interviews are going to help to shed some light on that. So far, I think there's 3 completed. We'd like to do somewhere around 45. So we're beginning to get some insight into what's happening from the patient's perspective. So we're excited about that. The strategy is designed to be sustainable and adaptable to other kinds of settings. And again, we were very purposeful in thinking about an electronic health record, an EPIC, which is the biggest market share within the states. All states have a Quitline. Eligibility, again, varies, but that process of connecting and using those resources is something that we're after to be able to scale into other areas. So far, I think our evidence is good. The Metro Health and the feedback that I've given so far, they're excited about this improvement. It's certainly an efficient way to go. Seems to be working. We will continue to give feedback to those practices and encourage continued uptake. In addition to the qualitative interviews about the patient's experience, we're going to continue to collect data from electronic health record for at least 1 year out to be able to inform what those trajectories look like. And I think that we've got more detailed analyses planned. We'll be using a interrupted time series kind of analysis to better model what we're seeing and what we're learning. So other things that I think just are worth note and worth celebration. One is that this eReferral with the project of Metro Health and making the connection with National Jewish Health is the first in Ohio to do this, and we're actually only the 16th state in the country to have an active eReferral up and functioning with one site. Of course, it's an entire system, but with one system in the Quitline. So that I shouldn't feel bad that it took us 2 years to do it. It was an enormous amount of work, and a lot of credit goes to Metro and the IS system and other team members who I'll highlight in a minute. We have developed methods to assess the whole process, which is pretty exciting because a lot of folks would just have the front end piece and not really know what happens on the back end. So it's pretty awesome to be able to have all of that in the strategy for using it. And then we just, you can think about this as as a laboratory to be able to test. Now that the system is up and running, we can begin to tweak or examine other pieces or other places to send people that we can really start to understand how to better meet the needs of some subgroups. Try it out, see if it works, see what the effect is, and then potentially implement it as a system. So lots of people to acknowledge. My collaborators on this are listed at the very left. There are loads and loads of folks from Metro Health who are involved, including MTAs and nurses, other clinician representatives, trainers on EPIC who were instrumental in helping us think through the tip sheet. All of the IS folks in the different departments in which they exist in really making this happen. We also have been working closely with National Jewish Health and have had a number of people, but currently right now it's Kelly Nadine who's working with us. A couple of people from Ohio Department of Health. They, of course, are the state administrator of the Quitline. They're the ones who pay for it, shepherd those dollars to provide the Quitline. We've had patient representatives as part of our stakeholder group, and we've got Jenny Vidrine, who was the original developer of that Ask, Advise, Connect strategy as a consultant, and this was just at one of our team meetings last summer over at Metro Health. And with that, I'm going to go ahead and stop and take any questions or comments or recommendations that you have for me. Thoughts? Yeah.
The interviews you're going to be doing to debrief about this, are they just with people who accepted the referral, or are you able to touch base with any of the people who either declined or initially said yes, but ended up not participating to learn more about why they chose not to?
Yeah. We are. We've got 3 groups, and you've just basically described them. Those that actually enrolled, those that were not able to be contacted, and that was actually a comment back from the reviewers on this grant. How the heck are you going to contact them? And we said, we acknowledge that it's going to be difficult, but we'll resort to calling from a Metro Health number that they would recognize, a 778 number that they might recognize, they might pick up. We'll leave a message saying that that's where we're calling from about their recent visit, and do our best to say we want to hear from them about their story and about their experience. So that's a group. And then also the folks who said that they were interested, but then just chose not to enroll. There might be other subgroups. Those are our initial 3 subgroups. We'd like to hear and understand what's happening, and then we'll probably continue sampling other subsets within that so that we can just really understand and maximize what we're learning. Yeah. Yeah, Amy.
2 comments. One is on the issue with the MTAs not feeling like this was kind of in their scope of practice. I wonder if that's also an issue for the patients, because I feel like, well, if the person who's normally the one who's kind of taking my temperature and my blood pressure were to give me medical advice, I would feel a little, kind of like, well, who are you to give me advice? So I don't know if people have looked at what's the efficacy of having those referrals by, someone with more clinical potential.
Yeah, so I wouldn't call the advice the advice that's being provided is not clinical advice. It is just, it's a recommendation to quit. Most patients know that. And we've asked, and it'll come up too in the qualitative interviews, but patients do not seem to have an issue with that approach.
Okay.
And MTAs have adopted it. I think the advice statement is the least of their, it's working. It's not an issue. The one piece that we're hearing feedback on is the frequency with which it's happening. Right now, we're on a every patient, every visit schedule. And for some patients, there's a lot of visits. And when we were debriefing, there was an MTA that was saying, I can give you an example of when I didn't do this. It was just last week. Person came in and they had a visit in the morning and they had another visit in the afternoon. I did not do it in the afternoon. I'm like, okay, that seems pretty reasonable. But it's variable. It's hard to come up with a single rule that's going to work. But overall, they like the process. And I think, we talked a little bit, but we didn't act quickly enough on the idea of measuring MTA and nurse empowerment in that process. And I think the fact that we engaged them along the way about how to do it, how it would best fit their workflow, what would be meaningful, what they think their peers would feel about it, how should we present it to them, I think that went a long way in making this actually work and work pretty well. Yeah. Did you have a second question?
I do, but if other people have questions.
Yes.
So uptake was low among 18 to 34-year-olds, young adults, and we know that, right, there's just a lesser desire to actually talk on the phone.
Yes.
In that age group. So if this is such an effective connection, is it thinking from the Quitline's perspective of offering something, and do they have that, or is it integrating another option that maybe allows there to be triage within the referral from the MTA?
I think it needs to be earlier. So these, the data that I showed you for the Quitline were people who said, yes, I'm ready to quit in the next 30 days. Yes, I would like assistance from a coach or counselor, right? So that's a pretty unique subgroup as it is. But I think the difficulty of getting them on the phone in the first place is the bottleneck. So something else that might happen, and it could be that people, we try to make it neutral, but it's hard to say no when you're offered something. It might be good, you don't know, you're going to wait and find out. But I think having something in between might help. And I think that's an area that's rich for further study to find out what's a good fit for whom, what do they want. Does it make a difference to have choice? Right? And how do you get that choice option to people if they're not going to pick up the phone? Is it something else? Yeah. Yeah.
This might not even be a possibility kind of recommendation, but maybe if for a younger population, giving some kind of text reminder before you get the call.
Yes.
Might work.
Yes. We've actually had that conversation with the Quitline. We weren't, the answer right now is no, but we'll ask again. But yeah, I think that makes a lot of sense. So you can see with this system in place, there'd be a lot of opportunity to test something for a couple of months, see if it works, and if it does, great, do we choose to implement it bigger? If it doesn't, okay, we've learned that it doesn't work. But I suspect there are going to be some things that work for some groups and some things that work better for other groups. And I think our challenge in the next couple of years is to get that figured out. But that's a great suggestion. Yeah.
Actually, the idea came from my past experience. I used to work in a dental office as a manager, and we were doing a lot of recalls. Mm-hmm. And most of the phone numbers we were calling, either they are changed or they are not, responding or something like that. Yeah. So over here, I want to suggest, when as a Quitline, the most number is the one which are not responding, like 807 out of 1400. So maybe the suggestion is we can confirm the phone number before we transfer the record so that they have the right phone number to contact.
Yes.
Something like that.
Yes, and we do that. So remember, there's two places that they go. One is for the Quitline, the other one is freedom from smoking, which is internal. Mm-hmm. For the one that's going to the Quitline, there's a specific piece, and the medical technical assistants and nurses are doing it, confirming a phone number and what time of day they'd prefer to be, morning, evening, afternoon, preference. Not that the call's always going to come that time, but that's their preference. So we do confirm those phone numbers, yet this is what we're getting. So I think, again, from the qualitative interviews, we're going to learn a little bit more and maybe specifically ask about that. But yeah, that's a great recommendation. Yeah, that's clear.
Are process outcomes being collected for individuals who are getting referred to the Freedom from Smoking program? Because
Yes.
I'm thinking potentially, they are, okay.
Yeah.
Because I'm thinking that could potentially be rationale for expanding eligibility for
Yeah.
the Quitline.
Yeah, so they are calling from a 778 number, so Metro Health's extension is 778. What do you think the contact rate is for
Similar? Just lower?
other guesses? Contact rate for the in-house smoking cessation program is 50%. So calling from a recognizable phone number. There's something about that situation of saying yes, I'd like assistance, but I'm not really ready to pick up the phone. Maybe we text. Maybe there's something else that's going to help sort. Yeah.
On that note, the research that I've been doing about technology with underserved populations, a lot of people have the Obama phones that have a very limited number of minutes, and so they may not want to use those minutes up on the calls, especially if they don't know how long the calls are going to last.
Right. So one idea floating around is to text people with options, one of which is to enroll in text to quit, which is all text-based. There is web-based QuitLogics, which is a web-based, basically what you would get from the Quitline, but it's all web-based. So there are other options that wouldn't use a phone. I do believe that when the Quitline actually contacts somebody, they offer those options, but it's when they're connecting them by phone. So maybe it's something else. It would be great if we could get the Quitline partnering on this, but I don't know how feasible that is. But I think there's some other in-between options too that we can test out. Yeah. But I do think that the phone minutes is certainly an issue. Okay. Yeah, okay.
For the nicotine replacement therapy which is provided, the treatment which is provided, so how does that go? Like over the phone, they just suggest, or does the patient really go meet a counselor regarding the same?
No, it's so there is. This is my understanding, and India can correct me if I'm wrong, that there is an assessment, there's a recommendation for nicotine replacement therapy, something gets sent to a physician, their referring physician, which would be the physician of record for that visit, to sign off and say, yes, it's okay, and then 2 weeks, I think it's currently 2 weeks, get shipped, and it could be lozenges, the patch, or gum format. And if the individual engages in more counseling sessions, like they get through counseling session number 2, another 2-week supply will be shipped. Did I get that right? Okay. Yeah. So they don't have to meet face to face. It'll get shipped to their home. Okay. Yeah.
If a patient has multiple visits, is the 5 contact attempts, is that per referral per visit instead of one person can say, I want help 3 times? Do they get 15 contact attempts, or do they still only get 5?
I think the way it would work is that you have visit number 1, you say you want to be connected. There's up to 5 contact attempts to get that person and enroll them. If they're enrolled, they get up to 5 counseling sessions. It could be more, but it's up to 5. And for each call attempt, so each counseling session number 1, they will try 5 times to contact them. That's my understanding. That's what they say happens. So if they came back, so presumably if they're enrolled and they're getting counseling now, and they have another visit, and we have heard back from MTAs about this, that they might ask a patient, and the patient says, oh, they already contacted me, I'm getting sessions now. So we've encouraged the MTA just to congratulate them and say that's great, and move on. So it wouldn't create another referral at that point in time. But certainly they could If they chose not to engage at that point in time, came back 3 months later, 6 months later, and got asked again, and they tried again, that could happen. Okay. Yeah.
Have you looked at the median for the number of counseling sessions? See if there's differences, if there's some that are getting all 5 and then...
It's very few. I think we have 9 out of the 219 that got all 5, and were designated as complete.
And then if they, on the first call, if they offer them these other options that are web-based, do those count as sessions, or is that a separate intervention, so then that would end their counseling?
Yeah, that's a great question. My sense is that it's separate. It would be great if we have a way that we could track that information. That's a good thing we should follow up on. Okay. All right. Thank you, everybody.
Thanks, Sue. Thank you all again for coming. I just want to remind you that we have our next seminar coming up on October 11th, where Dr. Darcy Friedman will be giving an update on our FreshLink project, and her talk will be entitled Community Ambassador Model for Promoting Access to Farmers Markets. So we look forward to seeing you all again next month for our seminar. Thanks.